I love definitions. So I'm sure there's not a single surgeon in the room who could be labelled vain and frivolous. But the definition of futile is useless and ineffectual. And I would say the simple answer to this question is it depends upon the surgeon. Now, I'm going to have a senior moment here. The younger ones in the room, I hope, won't get too upset. But this appeared in the Daily Mail a while ago, and Mac kindly sent it to me. And I think this question of experience and training is becoming a very serious issue in these patients, especially the borderline patients that we're talking about, where mitral valve repair may or may not play a role. It really comes down to unfavourable pathology: rheumatic disease, endocarditis, post-infarction papillary muscle rupture, severe calcification, and ischemic MR. And I'm going to come back to Steve's very good question at the end briefly, if I may. Rheumatic mitral valve disease, yes, it can be repaired, and you've heard some nice brief interlocutors referring to this earlier on. I've been working with Chain of Hope, and in Ethiopia we've been repairing every single rheumatic valve we can lay our hands on, but that's a different situation because they don't have warfarin control. Here is a typical juvenile with rheumatic disease, and by extending posterior leaflet and so on, you can actually make these valves work. The other thing is, I think Jean-Louis pointed out this morning, in the early stages of rheumatic disease, the anterior leaflet particularly may remain very pliable. So there are things that you can do, and as he showed you, and particularly showing Carpentier's longer-term data, you can get some very good results. But what about in UK, USA, Europe? I think most people would still argue that valve insertion, and I use the word insertion, not replacement, and you'll see why at the end, I think this is terribly important, is best in almost all cases. There are exceptions. I've mentioned the very pliable leaflets, adequate subvalvular apparatus, the very young in terms of valve sizing and management of anticoagulants and active life and so forth. The acute disease I've already alluded to is a different proposition to the late disease. Pregnancy or ladies who want to become pregnant are also serious issues. So the general considerations, I think, are age, the desire for children, the availability of anticoagulant control, and other disease states affecting the use of warfarin. So there is a role. It's not futile, but I think you have to choose very wisely. The specific considerations in relation to rheumatic disease come down again to the experience of the surgeon. This is not one to start playing with at the beginning of your experience. And how pressing is the need to preserve the valve, pliability of the leaflets, and the conditions of the subvalvular apparatus that I've mentioned. Moving on to endocarditis. Now, there are very good publications in the literature, I'm not going to take you through them, showing that mitral valve repair in the setting of endocarditis can be extremely successful. Here is a lesion of the mural leaflet with granulation tissue and a caudal rupture, but you can see the kissing lesion on the anterior leaflet is also very extensive. And one of the most important priorities in any infective process is the need to remove all the infected tissue. There is a recurrence rate of up to 20 to 30% in the literature, both in mitral valve repair and replacement after endocarditis surgery. And that really comes down to lack of control of the infective process. So you must remove all the infected tissue. You need to de-roof and clean any abscesses. And of course, the age of the patient that you're dealing with will also contribute to your desire to try to repair these valves. A 43-year-old man who's got severe endocarditis with a valve that's repairable by an experienced surgeon is going to do better in the long term, probably, with a repair than a replacement. The same man, in the hands of someone who does 5 mitral valve repairs a year, is almost certainly going to do better in the hands of someone who has a mitral valve insertion. Here is another case of endocarditis, a leaflet perforation, and you can see other secondary lesions on the leaflets. These can be cleaned up and patched, and I would just throw in the added comment, when you patch these, as you heard Tyrone mention earlier today, always use a patch much bigger than you think. 2 reasons. One, when you sew it in, the available surface area is reduced, and secondly, most of these patches will constrict over time. Myxomatous disease. We've had a long discussion about this today, the Barlow's type valve. And again, as we were seeing in the data presentation by Ben Bridgewater, most surgeons can take the simplest posterior leaflet and repair it. But many surgeons doing 5 to 10 a year might be challenged by a case like this. And in these cases, would mitral valve repair be futile in their hands? And I suspect it will be a vain and inglorious result if they tried too hard. So the surgeon's experience is vital. Residual MR, as you've heard, is not acceptable. And a well-done mitral valve prosthetic insertion with complete, and I emphasize complete, subvalvular preservation may well be better in some hands depending on the age of the patient. And the last thing you want to do is have a patient with significant SAM after a long bypass run and then have to take it all down and put a valve in. Post-infarction papillary muscle rupture, as indicated here, in most people's hands, repair does not work. Because, of course, after the acute infarction, the edema of the muscle wall progresses, and the recurrence rate of mitral regurgitation after mitral valve repair in acute papillary muscle rupture, in every paper I've found in the literature, is quite high. And in these, you want a swift operation, you want complete competence of the valve afterwards, and you do not want to be going back there at days 8 to 12, which is not uncommon. So repair in this situation, I think, is very often futile, and you'll find this early recurrence in many cases as the infarcted papillary muscle degenerates. And in addition, beyond that, as the infarcted area, if it extends further into the ventricular wall, matures, and the fibrosis ensues with myocardial stretching, which takes us back to the last talk, secondary mitral regurgitation can occur in the mid-term. What about redo repairs? We're going to hear about more of this in a moment. They are possible in the hands of the experienced surgeon. There is often enough tissue to actually deal with. This one I did re-repair, and the patient's doing quite well long term. But you have to be very, very careful when taking these on. You mustn't take them on liberally. And again, a valve insertion with complete subvalvular preservation is an excellent option for these patients. Many of them will be in their 70s or more, and a tissue valve with complete subvalvular preservation gives you everything you want for these patients. So again, experience is everything. Depends what's left of the mitral valve, usually possible in experienced hands, but may need some bold moves. And this is what I was alluding to in the discussion on data. The boldness must go with the experience, not boldness going on its own. Particularly how to handle the anterior leaflet is important, age dependent, and again, valve insertion is not a disaster if well done. Tyrone gave a very nice exposition on the severely calcified valve, and for many people this is a step too far, but as he's shown you, complete decalcification of that bar, leaving the atrioventricular fat exposed with a generous patch, and in this case a repair of the valve, is possible in many patients. But you do this later in your experience, not at the beginning. And as I said this morning, watch out for the danger area around A1, M1, because this part of the ventricular wall extends out beneath the left coronary sinus of the aortic valve, which extends into the left atrial base, left atrial appendage base, is very thin. And if you don't patch support this through the aortic root, expect a leak which may well be fatal. Ischemic MR, the situation is even worse. Mortality is distorted by the timing of intervention. There's a huge lead time bias in when you operate on these patients, and that's discussed in virtually none of the papers. Where you operate on the patient in their disease process will almost totally determine the outcome that you've got. And this was shown beautifully in the initial presentation by Steve Bowling on his early results, when his cardiologist presented exactly the same results in JACC and showed a massive difference in outcome. In degenerative mitral valve disease, the problem's the valve, fix the problem. You've heard ischemic MR is the problem of the ventricle, and as ventricle geometry continues to change, MR recurs, hence the rationale for considering valve-sparing prosthesis implantation. Now, I can hear the sucking of air through the teeth of my surgeons out here, but I want to just run you through some of the points about this. Mitral valve replacement is associated with high surgical risk and the possibility of left ventricular deterioration. Isn't it? You've all read the papers. But actually, how many of you have read the papers? Not just the headlines, not just the conclusions. I'm going to show you some of the detail buried in these papers. Where does this come from? Is repair preferable for ischemic mitral valve disease? A very famous paper by Gilinoff. Were patients undergoing mitral valve repair same as those for mitral valve replacement? Their answer in the discussion, no. Group 2 were sicker, 89% class 3 or 4, as opposed to 35% in group 1. There was more papillary muscle infarction and rupture. So you're comparing apples and probably mangoes, not even pears. Is survival better after repair? It's dependent upon the patient characteristic, not the procedure. Operative mortality, 135 patients, 77% survive 1 year, and at 55% at 5 years for repair. Which patients benefit from which procedure? Well, patients with lateral wall motion abnormalities fared better with replacement, and patients with the most complex and severe conditions did not benefit from repair. This is not me. This is the author in his paper. How many of you read that when you read the headlines? Similarly, later on in the discussion, this extreme imbalance revealed that we are dealing with a wide spectrum disease. No surprise. Ischemic heart disease depends on the distribution of the disease in the coronary arteries, depends upon the distribution of the lesions. And that less ill patients with fewer sequelae in this myocardial damage whose surgery was preferentially underwent repair. In other words, the patients who got the least disease got the repair. Are they going to do better? Of course they are. Craig Miller wrote a very good review called REDOX, and does one do a ring annuloplasty or a more reliable caudal preserving mitral valve replacement? Question. The answer is not simple, but it's been portrayed to you, ladies and gentlemen, as being simple. Replacement's terrible, repair's good. I put to you that's not true. Historically, we've been handicapped by comparing very different cohorts of patients and attempting to guess whether repair offers a better outcome than does MVR. Truly apples versus oranges, and fallacious conclusions have resulted. So in whom might we implant a valve in ischemic MR? Without a doubt, there is a role for a mitral valve replacement, especially if all chordae are preserved. Again, none of these papers tell you, was it purely mural leaflet preservation? Was it mural and anterior leaflet preservation? Was it complete subvalvular excision? And when I questioned Mark about this, he didn't know. It's not in his paper. So they did not know what had happened to those patients. The sickest patients will probably do better, as every paper on this subject reveals, and those with complex MR may well do better. Lateral wall motion abnormality, you've already heard me refer to, excessive apical tenting, infarction of papillary muscle, and very ill patients representing an emergency. The choice of valve, given the poor long-term prognosis, may best be being a bioprosthesis because most of them are old. So let's turn to mitral valve repair in the ischemics. When is this futile? Well, a real phenomenon in downsizing mitral orifices for ischemic MR is mitral stenosis. Nobody talks about this. There are papers in the cardiology literature, though, none in the surgical literature. This one in JACC recently. Restrictive mitral valve annuloplasty in patients with MR creates functional stenosis. The hemodynamic sequelae associated with higher pulmonary artery pressure and worse functional capacity. The resting peak gradient correlated directly with systolic PAP and worse functional capacity in 6-minute walk time distance. And there's the p-value. So this downsize has downsize problems. So let's just quickly finish on how might you do a good mitral valve insertion, as a question came up to me in the interval, with full subvalvular preservation. The way I approach it, detach the anterior leaflet, divide it down the center, cut off the triangles, and take the edges of the leaflet back to either side of the outflow tract. You will not get SAM with that. The mural leaflet, I tend to detach it for the Myxomatous ones if I'm forced into it. With the Rheumatics, you may not need to. And place the leaflet back against the annulus as I've shown. Divide the mural leaflet in every case, because the arrangement of the papillary muscles and cords like that will restrict your orifice when you put it back against the annulus. Divide the leaflet and move it out laterally, and you'll increase your valve size by up to 2 sizes. And this is the final result with the anterior leaflet placed back against the annulus. Here's the outflow tract nicely opened up, and then you do what you feel best with the mural leaflet. So, in summary, the experience and skill of the surgeon is paramount in these situations, and for some it will be quite rightly so futile to repair, for others maybe not so. So it's a combination of experience and a combination of the patient that you're dealing with and the exigencies which exist in each patient, age, what's happening in their life.